You are welcome in this series of zygomatic and the maxillary trauma fractures, where we are going to talk about Lefort 3 fractures. As we move from Lefort 1 to the Lefort 2 and then Lefort 3, the anatomy and complexity of the fractures increases because the number of bones involved in every fracture increases from Lefort 1 to the Lefort 3. As Lefort 3 is much higher fracture, it is just like separation of the entire midface from the cranial part. It engages the bones like medial orbital wall, inferior orbital floor, zygomatic, maxilla, and the Lefort 3 is a continuous transverse fracture. It starts from the nasofrontal suture. The bones involved at the nasal part are nasofrontal suture and crosses the bridge of the nose to fracture the nasal septum. Coming to the medial orbital wall, run posteriorly along the medial wall of the orbit involving ethmoid and the lacrimal bones to the orbit apex. From the apex, it extends to the orbital floor or infraorbital fissure, extends across the orbital floor to the infraorbital fissure. From here, the line divides in two parts. Either it goes on the lateral wall of the orbit and continues superolaterally through the lateral orbital wall to the frontozygomatic suture and fracture through the zygomatic arch. Then the line comes to the pterygoid plates, fracture through the base of the pterygoid plate of the sphenoid bone, and it fractures the pterygoid plate at much higher level, floating face, and this is known as Lefort 3 fracture. Cranium detached from the skull base involved or the cribriform plate fractures, then the CSF rhinorrhea, malocclusion and airway compromised is the common clinical features of Lefort 3 fracture. This management in two parts. One is the initial management protocol, that is known as ATLS protocol, in which we will manage airway, breathing, circulation, and we will go for a neurological assessment on the Glasgow Coma Scale. Second, after performing the initial management, we have to go for the imaging, and here the CT is the gold standard. Then coming to the definitive management or the surgical management. The goal of the surgical management or the treatment is to restore the facial height, width and the projections. We must re-establish the occlusion, we must restore the orbit volume and function and achieve a stable skeleton fixation. Open reduction and internal fixation. The sequence of reconstruction is like bottom up or outside in approach. It can be up to the bottom down and into the outside approach. Coming to the Lefort 3 fracture fixation points. So we will go for a 3-point fixation in the Lefort 3 case, where we will stabilize the occlusion by intermaxillary fixation first. In the fracture must be in correct alignment before plating them to a rigid fixation. To achieve this thing, we must follow the anatomy, that is, we must restore the every buttress. Like we know, we have 3 horizontal buttresses and 3 vertical buttresses in the mid face. So the first horizontal buttress is this, that is the frontal buttress basically, then the inferior orbital rim buttress, and third is the occlusal plane of the teeth or the alveolar buttress. These 3 are the horizontal buttresses. We must have to restore the buttresses. Now coming to the vertical buttresses, so we have to restore this pyriform aperture buttress, zygomatico-maxillary buttress, zygomatico-frontal buttress and the pterygoid plate buttress if possible. But plating at a pterygoid is quite difficult and it's not possible. So we avoid this buttress and we try to fix the all other 3 buttresses like this one this nasomaxillary buttress, this zygomatico-frontal and zygomatico-maxillary buttress, and frontomaxillary buttress. So we have to fix all these three vertical and the horizontal buttresses. A Lefort 3 fracture case. Now coming to the plating. So plates and the design of plates must be according to the anatomy of the bone which is involved. Like if this nasal bone is involved, we have to go for continuous mini plates of 1.5 mm, or we can use a T-shaped plate here to stabilize this bone. When we are going to stabilize the infraorbital rim, we have to go for a orbital mini plate which stabilize this infraorbital rim both side of the fracture, here and here, because this line which is basically passing through the bones involved has multiple outputs. With Lefort 3, it's not always a pure Lefort 3. Number of times it's like a Lefort 3 line which is majorly a Lefort 3, but there is some minor fracture lines which communicate to the Lefort 2 region or somewhere else, because isolated fractures of midface are not possible, especially in cases of Lefort 2 and Lefort 3. So we get multiple fracture lines. So we have to stabilize maximum fracture lines, so that maximum rigidity and the stability of this complex we achieve. Secondly, we have to stabilize this frontozygomatic suture, because this is an important parameter, and we have to restore the content of the orbit by using orbital plates or orbital meshes. Talic anthus is a normal problem in the Lefort 3 fractures. So we have to correct the talic anthus, we have to correct the diplopia if that is present, and we have to manage according to all those things. Now in this case, I am going to show you the plating at frontozygomatico-maxillary, at infraorbital frontozygomatic, this zygomatico-maxillary. So we are going to plate mini plate with 2 mm of screw holes here, 1 mini plate with 2 mm of screw holes here, and 1 mini plate with 1.5 mm screw holes. Point to be noted here is that the length of the screws must be 4 mm or maximum 6 mm, not more than that. Especially around the eye or towards the nasal bone, it's always advised that we will go with a 4 mm screw, and if possible, if anatomy advised, then only go for a 6 mm screw. Try to stick with a 1.5 mm plate or 2 mm plate. It's always better to use a lesser number, because if somehow your screw get failed, you have an option to upgrade to a higher number to stabilize the fracture bone. So I will suggest you go with a 1.5 mm plate and 1.5 mm 1.5 mm and 4 mm in length screws around the orbit, and 2 mm plate with 2 mm into 6 or 8 mm screws around the maxillae. We have to hold and secure the screw like we had done in previous series. We will do the same here, and this time we are going to the fracture at frontozygomatic suture, and the choice of plate is a 1.5 mm plate with a 4 or 6 mm screw in length. Also going to show you what if our selected screw get loosened while delivering the screw to the plate hole. We have an option that we have emergency screws. So we can use a emergency screw here 1.7 mm in diameter with 6 mm in length, because 1.5 mm in diameter, 6 mm in length, normal screw is loosened in this hole. So here this time we are going with a bigger diameter screw with a slightly bigger length to achieve the stabilization. To expose arch, I will advise you either expose it directly over the arch, but the scar of the incision is not aesthetic, so we can use indirect approach, or we can use a high vestibular approach. But the problem of high vestibular approach is this, that we will able to reach to the inferior portion of the zygomatic arch, and it is very difficult to plate on the lateral aspect of the zygomatic arch. So if you want to plate on the lateral aspect of the zygomatic arch, it's always better that we will extend this incision a little bit and stretch it more to see the arch. Or you can go for a bicoronal approach, or you can go for a infraorbital approach and stretch it to see the arch. One more thing, one approach which is quite useful in reaching to the this arch, temporal region. Here we will go with a high temporal approach, so that the scar must lie in the temporal line, on the temporal hairs lines. So this is the last approach where we can go and directly see the arch if we want to plate the arch. Else you have to leave the arch if it is not interfering with your mandible, especially while opening and the closing. So if you want to indirectly make this arch again to the place where it is exactly, if it is not communicated badly, then you can use Rowe and Williams forceps from the temporal region, and you can elevate the arch again to form the facial symmetry. This complex anatomy make this picture very complex and difficult to treat. Even if we have our good knowledge of anatomy, there are a lot of other considerations like lot of lacerations and the soft tissue losses during this type of fractures make it quite complex. But a plating system like Bonker and the flexibility of plates which they provide us, the orbital meshes they provide us, the scalp meshes they provide us, make it a quite easy job to treat at Clifford 3 in a very precise time. Thank you and have a nice day.